Okay, so today, me, Haikal and Zaki would like to share about 3 topics. The first topic, child and neonatal seizures. Second topic, acute flaccid paralysis. The third topic, floppy infant. So without further ado, we go first to the first topic. So the first topic, I will present the first topic, child with seizures and neonatal seizures. My name is Abdullah Arif, 161161. So this is my content today. There are 3 parts. So the first 2 parts will focusing on child with seizures, and then the third part will focus on neonatal seizures. So first, we go to the terminology, a little bit pathophysiology, classification and etiology of child with seizures. So, seizures, or also known as fit or ictus, there are a few definitions, like I mentioned here. However, the most easiest one is from the pediatric protocol that give the definition: transient occurrence of clinical manifestation of abnormal, excessive or synchronous neuronal activity in the brain. So that is the definition of the seizures. Next, we go to the epilepsy. Epilepsy is the disorder of the brain characterized by an enduring predisposition to generate seizures and by the neurobiology, cognitive, psychology and social consequence of this condition. I think this definition a little bit difficult. So the most easiest definition is based on the clinical definition. So the clinical definition of epilepsy is any of the following condition. The first one, at least 2 unprovoked or reflex seizures occurring more than 24 hours apart, or any unprovoked or reflex seizures and a probability of a further seizures similar to the general recurrence risk after 2 unprovoked seizures occurring over the next 10 years, or the third, diagnosis of an epilepsy syndrome. I think the second definition is really confusing. I read it a few times but still confusing. So what's the second definition means? The meaning of the second definition is epilepsy is a disease of the brain causing at least 2 unprovoked or reflex seizures occurring more than 24 hours apart, or after 1 seizures if risk of recurrence are high. So high at least 60%. So that's the easiest one to understand the second definition. Okay, is it okay?
Yes.
So moving on to the epileptic syndrome. So epileptic syndrome is disorder characterized by a cluster of signs and symptoms. The syndromes are classified on age of onset, seizures type, clinical and developmental features, EEG abnormalities, and MRI brain findings. I will talk again after this. So next, status epilepticus. According to illustrated textbook of pediatric 5th edition, it is seizures lasting 30 minutes or repeated epileptic seizures for 30 minutes without recovery of consciousness. Okay, it is really important, without recovery of consciousness. And then this situation is a medical emergency. Okay, so status epilepticus is a condition due to failure mechanism responsible for seizures termination that eventually cause abnormally prolonged seizures. Okay, so status epilepticus can be divided into 3, which is convulsive, non-convulsive, and focal motor seizures. So when we can start the treatment for this status epilepticus condition? We start the treatment when there are 2 or more discrete seizures lasting more than 5 minutes, between which there is incomplete recovery. So when this happens, we need to start the treatment as soon as possible. So I will come again to this when I put the algorithm later. So a little bit about pathophysiology of seizures. So seizures can be conceptualized as occurring when there is distortion of the normal balance between excitation and inhibition. So as we know, the neurotransmitter for the excitation is glutamate aspartate, and then the inhibition is from the GABA. So when there is imbalance between these two, that will cause epileptic brain. So that's the idea of how seizures and epilepsy occur. Okay, can you move to the next slide, Kak? Okay. So this is the framework from the International League Against Epilepsy 2017, the latest one. So they classify seizures according to the onset. So seizures have 4: focal, generalized, unknown, and another one which is unclassified. And then the epilepsy, we divide it also into 4: focal, generalized, combined generalized focal, and unknown. Epilepsy syndrome, as I mentioned definition before, and then they also mention the etiology of the epilepsy that I will discuss after this. Okay, so next. So according to International League Against Epilepsy 2017, they divide the seizures into 4: focal, generalized, unknown, and unclassified. So focal, clinical EEG suggests that the abnormality is from the part of one cerebral hemisphere only. Okay? Only one cerebral hemisphere. For generalized onset, clinical plus EEG indicate involvement of both hemispheres. For unknown onset, there is no enough clinical information, and then we cannot determine whether it is focal or generalized. For unclassified, the presentation of the seizures is unusual, so we cannot decide which type of seizures. So we put it on unclassified. Okay, so on the left side, it is focal onset. On the right side, it is the generalized onset of seizures. Okay. Okay, so according to this, for focal onset, we can divide it into first aware or impact awareness. Okay, after we divide it into aware or impact awareness, we can furthermore divide into the motor onset, whether it is involved motor onset or non-motor onset. For example, if the patient have automatism, such as automatic behavior such as chewing, suckling, so we know that, okay, this is focal onset based on the clinical manifestation. After that, we classify whether the patient aware or impact awareness. So if it's aware, so focal onset, aware. The clinical manifestation, automatism. Okay, something like that. Okay, for focal to bilateral tonic-clonic, it is previously called secondary generalized seizures. It means that the seizures begin in one part of the brain, but can spread to the both sides of the brain later. Okay. So for generalized onset, we can divide it into motor or non-motor. Non-motor also known as absence seizure. So for generalized onset motor, tonic-clonic is the most common generalized seizures that happen. And then for non-motor, which is absent seizures, also known petit mal seizures. It is absent seizures is a seizures that causes a short period of blanking out or staring into space. So basically, it only affects person awareness of what is going on at that time only, and then it will have immediate recovery. For unknown onset, yes, we can know the clinical manifestation, whether it is motor or non-motor. However, we cannot determine it is focal or generalized. So we put it on unknown onset. For unclassified, because the presentation is unusual, so we cannot decide whether it is motor or non-motor. So we put it on unclassified. Okay. So there is, according to ELI 2017, they put new term. Okay. So the old term, simple partial seizures, which is focal seizures with no alteration in consciousness, and then complex partial seizures, definition, focal seizures with altered awareness of surrounding. The new term is focal aware seizures, or for the second one, the focal seizures with impaired awareness. So please use the new term instead of all terms. Okay, these pictures show some clinical manifestation of focal aware seizures and focal seizures with impaired awareness. So you can read after this. Okay, see, this is the examples of epilepsy syndrome. Okay, so there are a lot of epilepsy syndrome. So if you want to further reading, you can read the PITS protocol or go to the Nelson textbook, page 12,059. Okay, the causes of seizures. Seizures also can be because the cause of seizures is a lot. Okay, a lot. The common one is already been started. So like for example, infection. Infection can cause seizures. Metabolic hypoglycemia can cause seizures. Neurocutaneous syndrome, all this can cause seizures. So why this is important? Because all of this we need to ask or rule out during the history taking. And then for the neurocutaneous syndrome, we need to find the sign in the physical examination to rule out this. So it is really important. Okay. So this is the etiology of epilepsy according to ELI. So they divided into genetic, structural, metabolic, infection, immunological, and unknown. So genetic, previously called idiopathic epilepsy. The famous one is Dravet syndrome due to the mutation in the SCN1A gene. Okay. The second one, structural, previously called symptomatic epilepsy. For structural, there might be underlying structural brain disorder, such as stroke, trauma, tuberous sclerosis. And then for the metabolic, it is refers to the well delineated metabolic defect occur in the body, all of this. And then for the infection, for epilepsy, infection epilepsy is secondary to chronic infectious condition rather than acute. Chronic, that's why HIV, tuberculosis, malaria. And then for the immunological, it is secondary to immune-mediated central nervous system inflammation. If we know that the patient have epilepsy due to this, the first line treatment is steroid and intravenous immunoglobulin. For unknown, because we don't know the disorder, so we classify it as an unknown. Okay. Moving on to the second part of my presentation, how do we, as a doctor, approach the seizures? So the basic thing, history taking, physical examination, investigation, and management. So we go to the first one, history taking. Okay, so case scenario A, 9-year-old Malay boy was presented to pediatric clinic Sultan Ahmad Shah Medical Center for neurology assessment with history of multiple episodes of confusion for the past 1 year. So when we know this, the history taking begin. For epilepsy or seizures, basically we take the history from the witnesses. So most commonly, the parent, we take the history from the parent. However, if we think that the patient, the child, is mature enough to give the information that we need, so we can clock the patient. If not, we ask the parent or anyone who witnessed the incident. Maybe the parent have the video, you can ask the parent to see the video or something like that. Okay. So moving on to the case. So the doctor maybe will ask to the patient to elaborate more on the confusion. So the parent report, over the past year, the child has experienced the episode during which he develops a fearful look on his face and responds slowly or not at all to their questions. Initially, parents and pediatricians dismiss this as anxiety attacks. The doctor asks again, so why you come to the center today? Is the confusion worsened? I forgot. Before we start the history taking, it is better to ask the open-ended question. Okay. So recently, parents become more concerned when he developed chewing and swallowing movement during attacks. So when we got this history, chewing and swallowing movement, it's come to us, oh, maybe this child has seizures. So what is the further history that we want to ask? So we can divide the history that we want to ask into 3 parts, which is pre-ictal, ictal, and the post-ictal. So for the pre-ictal, as I mentioned, the history taking is basically to rule out another causes of epilepsy, of seizures, I'm sorry. So for the pre-ictal, is there any warning sign, such as fever, headache, photophobia that may indicate toward meningitis and encephalitis? Okay. And any diarrhea, vomiting that can lead to dehydration and electrolyte imbalance that can provoke seizures, we can ask. So then, what was the child doing at that time? Okay, so maybe the child hear loud noises or any stimuli that can lead to a hyperexplasia. So that's all can trigger seizures. Okay, is the child is asleep or awake? So we want to differentiate between sleep myoclonus versus seizures. So sleep myoclonus usually occurs during sleep and begins early in infancy, often in the first weeks of month of life during life. So we want to know about this. Any triggering factors, any provoking event, such as visual stimuli, flickering light, somatosensory or proprioceptive stimuli, anything that triggers the seizures. Okay. And then, was the child well during that time? Is there any fever to roll out infection? Is there any aura? Also aura such as flashing lights, seeing colors, or complex visual hallucination, we need to ask. And then, is there any epigastric discomfort feeling that can also make the child feel unwell? Give us clue that the child is unwell. So during the ictal or during the seizures, what we want to know is the duration. Duration is really important because like status epilepticus, if there is more than 5 minutes, we need to intervene. So that's why the duration is really important. So how many times? Only 1 or 2? Because like the definition, more than 2. So we need to know that. How often? Only it started last night or for the previous 1 month, previous 1 year? So we need to know all this history. And then for the cyanosis can happen due to irregular respiration, and pauses in respiration during the seizures. So we need to know the cyanosis. Any incontinence happen, any gaze deviation, eye rolling, drawing of saliva, clenching of teeth, and tongue beating. So we need to know the characteristic of the seizures when it happened. Okay, and then moving on to the post-ictal, we want to know how the patient feel after that. Is the patient consciousness impact or not? Okay, how long it came for the patient to come back to the baseline, to the normal person again? Okay, so this three part is really important. You can divide your history taking according to this. Okay, next, our case again. So the episode lasts about 1 to 2 minutes. However, it appears to take several minutes before the child recovers from the episode. Currently, he is suffering several attacks per week. Patient has little memory of these episodes. Although he says become frightening during the event, he reports that following the attack, he often had headache and fatigue. Although he is a good standard 3 student, during the past few months, he said he had to work harder in his classes to maintain his grades. So after the history, we need to ask other less basic history like past medical history, drug history, birth history, developmental history, nutritional history, family history, and social history. So for drug history, for the past medical history, you need to roll out other causes that I mentioned before. For the drug history, there are some drugs, medication that can decrease the seizures threshold, such as antidepressant. So maybe you want to ask the patient whether they take the medication or not. For the birth history, is there any problem during the birth? Is there any difficulty? So we need to know about that. And then the developmental history, because some seizures can delay the developmental. So the developmental history is really important. We want to know the current condition of the patient. And then for social history, like abuse, is really important. Family history, you need to ask all of this. Okay, moving on to the case. He had history of 2 episodes of febrile seizures at the age of 13 months. These seizures, which were separated by 4 months, occurred early in the course of viral fever and last for 2 minutes. Patient was not prescribed with any anti-epileptic drug at that time. No family history of epilepsy or other neurologic condition. According to Pitt's protocol 4th edition, there are probability about 2 to 7% febrile seizures patient can develop subsequent febrile seizures or epilepsy. So there are chance for this patient to develop epilepsy. So moving on to the physical examination. Okay. Physical examination, go to the general examination. Yes, it is really important to know patient conscious or not, how respiratory, is the patient in respiratory distress or not, dysmorphism. We need to look for any abnormal features in the body because dysmorphic features of syndrome such as Fragile X also can cause epilepsy. So those with Fragile X syndrome can have higher chance to get epilepsy. So we need to know all the dysmorphic feature. And then the sign of head and trauma, because head and trauma can cause brain injury. Vital sign, I think all of us know, is basics. Anthropometric, height, weight, and head circumference. We need to take all this and plot on the growth chart. And then if the parent have the book about the child growth development, we need to know whether there is developmental delay or not. So because we want to intervene, if there is delay, how much the delay? So this anthropometry is really important. And then for the skin examination, like I mentioned before, there are some cutaneous stigmata of neurocutaneous syndrome that associated with epilepsy, such as tuberous sclerosis, neurofibromatosis, Sturge-Weber syndrome, and then if there is abuse, of course, there are bruises. Okay. So this is the picture. This is the Sturge-Weber syndrome. Okay. stage Febrile syndrome, this is the distinctive port wine stain on the forehead, scalp, and around the eye. This stain is a birthmark caused by an overabundance of capillaries near the surface of the skin. So that's why it's become red. So we go to the tuberous sclerosis. So you can search for this, periangual, fibromas, ash leaf spot, this one. Macam daun. So this one, angiofibromas. And then I think the most, I think all of us know, neurofibromatosis, Cafe-Au-lait spot. Okay. So all of this is important to know, to look for during the physical examination. And then another important examination, neurological examination, tone power reflex, and then Kernick-Buzenki for meningitis, check for the nerve coordination and gait. For the eyes examination, check for any increase ICP increase, intracranial pressure, the fundus examination, and then for ear and throat examination to find any source of infection. For child maybe have ear infection, so we need to know, we need to find this. Again, we move to the case. His vital signs, general examination are unremarkable. His neurological examination is likewise unremarkable. Cranial nerves are intact with no facial asymmetry or sensory deficit. Power, reflex, are normal and symmetric. Coordination and gait are intact. So the diagnosis. So is there anyone who can give us what is the diagnosis for this patient? Anyone want to try? Anyone want to try? He has swallowing, chewing.
Focal seizure with impaired awareness.
Okay, baik. Oh, distinction. Okay. So due to all this, he has change of facial expression, impaired consciousness, followed by a post-ictal confusion. So the doctor gives the diagnosis is focal seizures with impaired awareness. Okay. So investigation and management. Okay. Child with first seizure is defined as one or multiple unprovoked febrile seizures within 24 hours with recovery of consciousness between the seizures. Okay, so in the investigation, I think routine investigation, lumbar puncture if indicated, toxicology screening, EEG is recommended. I need to mention again, EEG is to support only because epilepsy or seizures is clinical diagnosing. Okay, just to support. And then maybe we can do neuroimaging such as MRI if indicated. So for the management, for the first seizures, we treat individually, case by case. Usually, first episode, we didn't give any medication. Okay, but if it's epilepsy, if we think it is epilepsy, we can start with anti-epileptic drug. But the general, for the first time seizures, no anti-epileptic drug given. Okay. So because from the case, the patient has febrile seizures, history of febrile seizures, so I put here. Febrile seizures is seizures occurring in association with fever in children between 3 months to 6 years old of age, in whom there is no evidence of intracranial pathology or metabolic derangement. I think the investigation you can read. The most important part is the lumbar puncture. Lumbar puncture only if there is indication. If not, please don't do the lumbar puncture.
If you have 7 minutes to finish, please.
Okay. I try my best. Okay. So for the management, you can avoid excessive clothing, use antipyretic, first aid measures, and for the high risk of recurrence, you can do the rectal diazepam. For investigation, with second febrile seizures, so again, it is blood, example, FBC, again, just to exclude metabolic cause and before I start anti-epileptic drug. Genetic studies only indicate when the etiology is not found. So EEG, just to support the clinical diagnosis. Neuroimaging when there is indication. If no need to do it. So for the patient, EEG temporal lobe spike, normal finding. So how we manage the patient. So this is the principle of anti-epileptic drug therapy. So we need to classify. That's why I already mentioned how to classify. So treatment only when there are 2 episodes. So for the first episode only, no need to treatment. Monotherapy as far as possible. Only if the add second drug if the first drug failed. Okay. If not responding to treatment with 2 anti-epileptic, you can try surgery or ketogenic diet. Some drugs such as carbamazepine can cause vitamin D deficiency. So when we use this for long time, please give vitamin D supplementation. Okay, this is anti-type of anti-epileptic drug. You can read epileptic syndrome. Okay. The side effect. Okay, so for the management, I think status epilepticus, I think I need to mention this because it's important. So child with seizures, more than 5 minutes, impending status epilepticus, we can give PR diazepam and buccal midazolam. So if there is established status epilepticus, which is seizures persisting more than 30 minutes without full neurologic recovery, so we can give IV diazepam or IV phenytoin, but mention here, dilute it with 0.9% saline because phenytoin can cause venous irritation. That's why we give normal saline. We dilute it with normal saline. Okay, so if the seizures still occur after the 5 minutes, so the patient already enter early refractory status epilepticus. So refractory status epilepticus is when we already give 2 medication, but still the patient have the seizures. So early refractory status epilepticus. So when it come to here, so we as houseman after this, we need to consult the MO, then the MO will consult the pediatrician. So all after this, we give midazolam, phenobarbital, all of this under the supervision of the consultant. So please refer to the consultant. So not to forget the basic one, ABC, airways, breathing, circulation. Okay. So for this patient, we just treat with monotherapy. So when it's refer, immediate refer, and if there is developmental regression and fetal spasm. I think this one is important. Okay, this one is important. We need to educate and counsel the patient, and then need to tell them that they need to take the anti-epileptic drug. Okay, and then if avoid watch TV in brightly lit room, avoid sleep deprivation. You shower with bathroom door unlocked because sometimes seizures can happen in the bathroom. If the bathroom is locked, we cannot enter and help the patient. So please don't unlock. And then please cycling, climbing, because it can cause harm to other people. Educate about the emergency treatment, and then for children, we can inform the teachers and school about the condition, so they know their student have the problem. So first aid, the parent need to know, do not panic, remain calm, loose the child clothing, especially around the neck, place the child in the left lateral position, while any vomiters or secretion, please, this one is important because many of us don't know about this. Please do not insert any object into the mouth, even if the teeth are clenched. Okay, so some people tend to put something in the mouth, so it's wrong. Actually, it's wrong. Do not give any fluid or drug orally. So stay near the child until the seizures is over and comfort the child. So neonatal seizures, I cannot, due to the time limited, you can read after this the case scenario. I'm sorry. So the introduction in neonatal seizures is seizures that occur within the first 4 weeks of life in full-term infant and up to 44 weeks from conception for premature infant. This definition according to Medscape. So seizures are the most common manifestation of neurological dysfunctions in the newborn, especially during the first 10 days of life. So this is the causes of the neonatal seizures. Okay. The commonest one, this hypoxic ischemic encephalopathy. Okay. So this is also the etiology. So the clinical manifestation, the patient, the baby may be presented with subtle apnea, oxygen desaturation, eye deviation, altered consciousness, floppiness, and or generalized focal clonic or tonic movement. Okay, you can read the case scenario and then you can know what is the clinical manifestation of the baby. This is the clinical classification of the neonatal seizures: subtle, clonic, tonic, and myoclonic. So the physical examination, same. Thorough history is important. Physical examination, check for the fontanel, is that the bulging of the fontanel, any dysmorphic features, and then do the neurophysiology assessment, any reflexes of the baby, check, and then do the investigation, tortures, important septic screen, maybe there is neonatal sepsis, so it all is important. Okay. So this is additional investigation. Case scenario you can read after this. So in acute setting, we can give anti-epileptic drug intravenously. So if they are prolonged, if we prolong anti-epileptic drug, only if they have all this problem. So can you read after this? Okay, so this is the guideline for the management of seizures. So first, ABC, IVSS, dextrose, and then we need to confirm the seizures with EEG if possible. If not, it's okay. If possible, so start antibiotic in clinical suspicion of meningitis, neonatal sepsis, and then therapeutic hypothermia in infant fulfilling criteria. Okay, I will talk about this after this. So first, seizures ongoing more 5 minutes, we give IV phenobarbital. If going more 5 minutes, IV phenobarbital again. Still ongoing, phenobarbital until midazolam, and then still ongoing, we can give phenytoin or obtain neurological consult. So it's something easy like this. Okay. So maybe we can know that IV phenobarbital is one we can give to the patient with seizures in the neonatal seizures. Okay, so for the therapeutic hypothermia, just want to give the information. Is we want to lowering the body temperature so that the metabolic rate allows cell more time to recover from the neurological damage. So we want to cool the baby about 33.5 to 34.5 for 72 hours. After that, we try to increase rewarm again the baby. So that's the therapeutic hypothermia. But I don't know whether we do this in the practical setting because I didn't see it now. So maybe I just may share about the therapeutic hypothermia so all of us can get the idea. Okay, so for the neurological disorder, the normal development. Okay, so chance for if HIE, so for normal development only 50%. So the prognosis is really important. Okay, so this is my reference. I'm sorry because there are too much slides. I don't know how to make it more little slide. So I'm sorry. So is there any question you want to ask? So I open the question to the floor. Any question?
Raoub, can you go to the definition of status epilepticus?
Can scroll. Tak. This one. Okay. Okay, but
can you press the next button? So for the when to start treatment, is it really have to do after 2 or more discrete seizure, or if the patient come with seizure more than 5 minutes, even if one seizure, we can start with the treatment for the status?
okay. Actually, I got this from the PBS protocol. It says that 2 or more discrete seizures. But in my opinion, I think if first seizures, however, already more than 5 minutes, I think we can intervene as status epilepticus. We can give IV midazolam first. I think. I'm not sure, but maybe doctor can answer the question. But I think if I will like to intervene because the duration more than 5 minutes.
Yeah. Okay. Thank you, Arif. Really, you try to collect a good therapeutic knowledge, okay, which is part of our essential. But usually, if we came to deep point, we need to go for the specialist in that area, okay? Even in Islam, to be educated on someone, it's better to be only educated by book. Because sometimes the book may be misunderstood. It may be a bit edition before there is new update. The one who is writing is not a fully specialist in that area. Okay, even they said for one of the scholar, Ibn Hazm, they said he is very, very big example, but he has no teacher for him. Okay, they consider it one comment. So thank you very much for your good effort and try to sort some issue like the definition, which I didn't advise you at all. We need to be confident, but not over. For you, this one looks easy, so this one not acceptable, or no, it is not like that. Usually, when doing definition, sometimes someone concentrate on the pathophysiology, someone concentrate on the clinical application, someone if try to collect the etiology and blah 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 blah. It looks complicated, but sometimes it is the working one. Okay, so please, if you mention for many author, just read. This is that. Even if you prefer, I found this one easy for me, but don't attack the other, please. Okay, because to be professional, beside to be competent, is very important. Our goal is to be more professional, okay, and more competent and more safe. There is a lot of responsibility with time when you, inshallah, will start to practice your medicine within few months, less than 1 year. So take care about that. For the issue is, if the patient already has a convulsion for up to 5 minutes, we will consider him in the school as a status epilepticus, and we'll go through the same flow chart of treatment of status, okay? Because we are assuming if past the 5 minutes, it may be continue. So it is not acceptable at all. You are in the hospital and some patient call you, or the emergency department to call you. We have one patient, doctor, he is now convulsing for 5 minutes. Tell them, oh, it is okay, just contact me after extra 25 minutes. I need to eat, and they do something and they see another. It is not like that, okay? For the issue of hypothermia is applied for neonates. Okay, it is known as therapeutic hypothermia if the patient has severe perinatal asphyxia and accompanied by convulsion. This is one of the criteria to consider. There is a long series to consider therapeutic hypothermia, which must occur very early within 6 hours of delivery, and it will continue for 72 hours and like that. So it is one of the proved and the standard line of treatment of baby with hypoxic ischemic encephalopathy, including if he has convulsion. Also, it is applied now, I think, for adults if they have arrests. Some are applying the same one. Therapeutic hypothermia. Anyone need to ask questions?
Thank you,
Okay, thank you, Arif. I will offer you 8.5 today because you have a good job, but please remember my advice. Always come to the highly specialist in that area. Try to retrieve the recent and the updated books and the last version, okay? Try be confident but not over. Hoping the best for all of you, inshallah. Okay? The second one is against Arif. So now, Haikal now is going to speak to us. Is it Anis? Oh, who will be acute flaccid?
Me.
Okay.
Haikal.
Okay, go ahead.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Okay. I hope everyone is able to retain their consciousness. So I am Anis Amiraika bin Zahari. My metric number is 1617639. So the topic today is acute flaccid paralysis. Okay, before we start discussing about the topic, I would like to draw some attention with this complaint. So a 12-year-old boy came for bilateral lower limb weakness since 2 days. So I would like to open to the crowds. If anyone have any idea what to ask, I open
As
to the
if there is any previous infection, because it can be Guillain-Barré.
Okay, good. Anyone else would like to try?
Progression of the weakness. Is it ascending or descending?
Okay, good try, but thank you. Anyone else? Last. Okay. Or if no, so okay, maybe we can proceed. Okay, the content today. First, we will go to the introduction. In the introduction, I would like to emphasize the definition, the case definition, and a surveillance program. So I would like to talk some idea about the surveillance programs. And then the second subtopic is etiologies, the causes, and how does the etiology we can organize the classification. And then the third is how to approach the patient or the child with acute flaccid paralysis. So what history we want to ask, physical examination we like to assess, and also what to order in the investigation. And the last one is I would like to share some diseases. Probably one of the comments. The example, transverse myelitis, Guillain-Barré syndrome, and also the quite important disease, which is poliomyelitis. Okay, for introduction, so go with the definition first. I'm taking from pediatric protocol, the 4th edition. It says that acute flaccid paralysis occurs when there is a rapid evolution of motor weakness. It is less than 4 days and with a loss of tone in the paralyzed limb. This excludes weakness due to trauma and spastic paralysis. Why we want to exclude spastic paralysis? Because of the term here used, flaccid, right? So it is opposite. So if we broken down the terms, acute, rapid onset, flaccid, loss of tone, and paralysis, limb weakness. So sometimes patient can complain that the child having lower limb weakness, or the child refuse to walk or something like that. It may suggest there is a limb weakness. And the other thing is acute flaccid paralysis is an emergency because we're afraid that the disease might progress, involve the respiratory muscle, so patient may, it is a life-threatening. Meanwhile, WHO, World Health Organization, mentions that any child under 15 years old age with acute onset of focal weakness or paralysis, including Guillain-Barré syndrome, or any person with paralytic illness to at any age when polio suspected, characterized by flaccid, which is reduced tone, without or other obvious cause. So, in case definitions, in Malaysia, any child aged less than 15 years old develop acute onset flaccid paralysis, we must rule out polio infections. So in order to rule out the polio infection, we need to take a stool sample, at least 2. You can read here, laboratory workup. 2 stool specimens should be collected, interval at least 24 hours apart, the first and the second stool. And then it is best that we take the sample within 14 days of onset, within 2 weeks, the presentation of AFP. Because one of the common cause of the AFP is poliomyelitis. So we want to rule out that. And then there is a surveillance program done by Global Polio Eradication Initiative, or we can call it GPEI. So it is a public-private partnership led by national government with collaboration with WHO, UNICEF, Rotary International, CDC from USA, Bill and Melinda Gates Foundation, and also Gavi, the Vaccine Alliance. So the main goal of this program, we would like to achieve a total eradication from polio. However, nowadays, due to we have a vaccine in 2 forms. One is through oral or through intramuscular. Most of the country have achieved total eradication, except for this endemic area, the Pakistan. This is from 2020 years. In 2020, the endemic countries are Pakistan, Nigeria, and also Afghanistan. Okay, so apart from the surveillance program, so in Malaysia we have a protocol. So if we encounter with such cases, AFP, so these are the steps that we need to follow. First, of course, we detect the AFP, and then like from the previous case definition, after we've suspect or diagnose, we need to notify within 24 hours. This is very important because you might face fine if you fail to notify, because it is a part of the surveillance program. And then after you detect a report, and then you need to collect two specimens we want to rule out. So these are the process you can read later. So we collect we take the stool to sample 24 hours apart, and then we need to transport to the IMR, Medical Research Institute. So it is transported through cold chain. And then after that, we need to follow up to 60 days. Okay, so lower limb weaknesses, the causes we can easily having this one in our mental image. So the issue with this image, it doesn't include the spinal cord. So usually we can classify in a bigger classification. It is either myopathy or also neuropathy. And if it is neuropathy, it can happen upper motor or lower motor. So it can lead us with specific features, right? And then we can further broken down the neuropathy. It can be at level of anterior horn. So if patient, if the pathology is here, patient might have lower limb weaknesses and also fasciculation. And same goes to the others, like it can be happen at the motor neuron, it can be happen at the peripheral nerves like Guillain-Barré syndrome. If anterior horn or motor neuron, it can be due to the poliomyelitis. So you can read the diagnosis here. And then if it is happen at the junction, neuromuscular junction, we can for the examples are botulism or myasthenia gravis, and it also can happen by muscles. So after this, with this in the back of our mind, we can easily what to know, what we like to assess. We can guide us, and also it can guide us what the investigation we would like to order. And then this one, it includes the upper motor lesions, which is acute transverse myelitis, usually happen here at the spinal cord, the grey or white matter. And sometimes a patient can having a space occupied lesion, it's either abscess or any tumor. So this picture is better in terms of the inclusion of the spinal cord. So these are the ranking in terms of commonness. The Guillain-Barré syndrome is the topmost. And then the second one is CNS infection, and then transverse myelitis, non-polio enterovirus, and hypokalemic due to metabolic derangement of potassium, and also last one is viral myositis. So polio is not included here because of we almost achieve eradication due to the vaccines. I think last year or last 2 years we have a outbreak due to from Myanmar, I think, if I'm not mistaken. Okay, we go to the diagnostic approach. Okay, history. So when a patient come with lower limb weakness, we like to ask about the onset duration. It's because we want to see it is a acute one or it probably take a longer time to develop. Or we would like also to ask about the distribution, either is symmetrical or asymmetrical, like Guillain-Barré syndrome and transverse myelitis usually occur symmetrical. Meanwhile, for poliomyelitis, mostly they having an asymmetrical presentation. And then we like to see the progress, like Guillain-Barré syndrome, mostly they in ascending fashion. And some other disease like, if I'm not mistaken, botulism, they can present with a descending. And also fever at onset. Polio, it is concomitant. When we have a lower limb, at the moment, they're having a fever. If we have a gap, like 2 weeks prior to the lower limb weaknesses presentation, they're having fever, so we might suspect of GBS or Guillain-Barré syndrome. So okay, the other diseases like couch spine, I think you guys still remember couch spine is due to the tuberculosis punya abscess settling at the spine. So we would like to also rule out any trauma to the head or neck. And then we also would like to ask any abnormality with sensation, because if there is a neuropathy, and sometimes in Guillain-Barré syndrome itself, we have several variants or subtypes. So this may leads to specific what subtypes. And then sometimes if there is nerve stiffness, it may suggest a certain type of presentation in poliomyelitis and also other diseases. And if there is an involvement in bladder, so this suggests to what extent the disease have progressed. And then there is also a ANS, autonomic nervous system symptom presentation. It can be associated with GBS. So patient can have a lebay in vital signs like that. And then if there is any evidence of prominent ptosis, the drooping of eyes, so it may suggest myasthenia gravis. Myasthenia gravis is one of the prominent feature is the ptosis. And it can be also facial weakness. So if Guillain-Barré having a cranial nerve involvement, so it may also present with facial weakness. So if there is any feature of fluctuating symptoms or fatigability, this means like if at the early day they didn't have any weakness, but over prolonged use of the muscle or any activity, it can start to have this one weaknesses. So it may suggest myasthenia gravis. So if there is a painful spine movement or spine tenderness, so we must suspicious of spine trauma or any abscess settling there. Or if there is a respiratory insufficiency, this may guide us how we want to intervene, because there is a respiratory muscle involvement. And then if there is a muscle tenderness, we might suggest viral muscle myopathy, like viral myositis or severe Guillain-Barré syndrome can also affect the muscle. So other important thing like our friends mentioned that we can ask about preceding febrile illness for Guillain-Barré, or we can also ask about immunization, like if the patient didn't complete the schedule, immunization schedule, so we might worry of poliomyelitis, or sometimes the vaccine itself may induce the poliomyelitis, some type of the strain of poliomyelitis. In physical examination, I hope everyone still can have the energy to pay the attention. Okay, the main we would like to do the comprehensive neurologic examination. At least we would like to have idea it is either is upper or lower motor neuron, so we can correlate with the etiological picture before I have present, right? So we would like to assess if the distribution, the degree of weakness, and don't ever forget the cranial nerve also. And if the tone is reduced, if there is a suggest lower motor presentation, so we might suspect like GBS or poliomyelitis. If transverse myelitis can also present like lower motor at the beginning phase because of the spinal shock, and then however in after a period of times like weeks, it can become spastic, the presentation of the upper motor neuron. So I think you can see. The other thing we like to assess is also the autonomic features, like if there is an involvement of bowel or bladder. We check also the vital signs, and the other thing we can check is the skin, if there is a sticks or fang marks due to the snake bite, because there's we still remember like Elepidie punya snake, it can cause inject the neurotoxin, so it can present with neurological symptoms. So special tests we can assess for fatigability test or tensilon test, like for myasthenia gravis. We can also test for SLR test, straight leg raising, to suggest any radiculopathy. So in investigation with the picture previously, so if you suspect the disease at the spine, we can do the MRI to check any spinal cord compression, or it is helpful for transverse myelitis. After which I show what is the finding. In CSF analysis, if you suspect infections or you suspect transverse myelitis, he has its own finding. And the most important thing is it is diagnostic for Guillain-Barré syndrome, which is the albuminocytological dissociation. So after that, I will tell about it. And then if you suspect it is happen at the axon, the nerve, So we can order for this nerve conduction velocity and also electromyography. And if you suspect it is myopathy, like patient have a pain at the muscle prominently there, so you can order the exam marker for that, which is a creatine kinase. CKM, creatine kinase, okay. Some other, you can also order serum electrolytes for like potassium deficiency, low in potassium. So this is the feature that we would see in CSF analysis. So we check the appearance, the protein, the glucose. So of the features, it can suggest what kind of infection we have if you suspect any infections. So before I end this topic, I would like to share some diseases. So we go to the first, the acute transverse myelitis. As I have mentioned, it is occur here. Here. So it is a condition characterized by rapid development of both motor and sensory deficit at any level of spinal cord. Usually the spinal cord level is the mid-thoracic, and then the common age is 3-year-old below, and it is defined as evidence of spinal cord inflammation. We can see it at MRI. There is an enhancement or intensity, or from CSF we can see pleocytosis, or we can order immunology G index. So the presentation, patient usually have a preceding with history febrile illness or immunization history, and then it may start with sensory deficit, and then can progress with motor weakness in truncal and also appendicular muscle, the limbs, and the pain usually neck or back, depend on level of segment. Patient can sometimes have allodynia. Patients sometimes have paresthesia, and for the paralysis, initially irreflexia, and then it becomes spastic, like I have mentioned. It is rarely to be unilateral. Associated issues is we need to anticipate the urinary involvement, priapism, vision loss, if any associated with ophthalmic optic neuritis. If sometimes patient have spinal shock and also autonomic dysplasia. So these are the differential. I think you can read this letter. Okay, this investigation, we would like to see MRI is quite diagnostic. So we can see the any intensity here. You need to see at the T2 weighted image of MRI. I think this one is T1 because there is no enhancement of fat here. So usually we would like to see this intensity, high intensity. I'm not sure you guys can see it clearly or not. After this, you can zoom in. Okay. Apart from that, we would also like to rule out any compression by mass or space occupation. So in CSF, we can see there is elevated in mononuclear cells, and there is a myelin basic protein and also immunoglobulin level. For antibody, if there is a involvement of eye presentation, like vision loss, so we will order NMO antibody. So this is diagnostic, it is MRI because of spinal. So the management, we usually treat with a high dose steroid, which is methylprednisolone. If we not respond, we can, this is the choice. Either we can intravenous immunoglobulin, or we can do the plasmapheresis or plasma exchange. We can also order like rituximab and also cyclophosphamide. And then we need to follow up the child. So that's all for transverse. And then we go to the GBS, the lower motor here. Right. Okay, here. This is lower motor. So usually the GBS we attack here because demyelination or axonal degeneration. So you can see this AMSAN is the variant, the subtype of the Guillain-Barré syndrome. So it is an autoimmune or post-infection disease. The other name we can use is post-infectious polyneuropathy. So usually the presentation, we have a history of non-specific infection, usually GIT or respiratory infection. So the organism it can be bacteria or viral. Usually the most common is the Campylobacter jejuni and Mycoplasma pneumoniae. For the viral, can be a cytomegalovirus and Epstein-Barr. And then the presentation, the famous one, the classical presentation is the symmetrical ascending. So usually it's that lower witness at the from below up to here. If involve upper parts, we might afraid of the respiratory punya failure. So the neck, back and buttock and leg pain can also occur. So so this when we have a paralysis, so witness can progress to inability or refusal to walk, and later on it can become flaccid tetraplegic if involvement is up to the above the umbilicus. And then usually it is a areflexia or hyporeflexia. If the bulbar involvement, so we might afraid there's a respiratory insufficiency. So dysphagia and facial weakness are often an impending sign for us to tell it is might be respiratory failure will happen. And then the pathophysiology, to put it simply, it is a molecular mimicry because it is autoimmune. So there will be an autoantigen. So in the the C. jejuni, you have a protein which is an oligosaccharide. So it mimics with ganglioside on the our neurons. So that's why there is when our immune cells mistakenly see ganglioside as the protein from the bacteria. So it will attack and then it causes segmental demyelination. So here we can correlate with the investigation that we would like to order. Like we can order for nerve conduction study and also EMG, right? So there is effect with the velocity. So apart from that, the diagnostic for GBS is albuminocytologic dissociation. Basically means that there is a protein elevation, but there is relatively there is no increase in pleocytosis. There is no pleocytosis. So MRI we like to order if you are not confident enough with your diagnosis, just to rule out spinal cord injury. And apart from that, we can order this electrophysiological study. It also can help in severity. Apart from that, you can order the antibody, anti-gangliosides antibody, to give the subtypes of the GBS. Other is rarely needed, like the muscle or sural nerve biopsy. Or also, we would like to find the specific cause, which is the Campylobacter infection. It doesn't give any change in treatment. So for the management, previously it is high dose steroid, but here we give intravenous IVIG for 5 days, or sometimes other. It depends on country. I think other country might do it for 3 days. I think it depends. Then if not, if sorry.
Immunoglobulin is the same dose, but there is many regimen. It means you are giving him 2 grams.
Oh,
some give 0.4 for 5 days, some give 0.7 for 3 days, some given 1 milligram today and tomorrow. It depends on the specialist assessment. Okay.
Okay. Okay. Thank you, doctor. So if it is not effective with IVIG, we might consider the alternative like plasmapheresis, the exchange of plasma, or the other immunosuppressive drugs. Steroid is not effective. So the other, we would like to cater the nutritional support, pain management, and also the prophylaxis for DVT because of the prolonged bedridden. So the last one.
But you must insist about the mechanical ventilation. I mean, this patient, if the disease became worsening, even the intercostal and the diaphragm will be very weak, so can go to respiratory failure. That's to say he need close observation for his respiratory effort, and if we come to certain point, you need to intubate and it is life-saving because he will be intubated for short time, 1 week or 1 week plus, and after that he will retrieve, inshallah, and he can survive. That's why mechanical ventilator is one of life-saving in that condition.
Okay. Okay, we go to the last. Okay, sorry, okay. Okay, we go to the last one, the poliomyelitis, the infection by sorry.
Michael, you have 5 minutes maximum, please.
Okay. This is the last one. So this is poliomyelitis, basically the infection by poliovirus. One type of the enterovirus, because enterovirus we have several types. So poliovirus is the under the enterovirus, because you can see that there is a other infection at the motor neuron also by the enterovirus. So I think this one, the transmission is fecal oral. We would like to emphasize the fecal oral. Sometimes kita we might tembak-tembak it is respiratory, right? So I think we need to take note this. It is fecal oral. That's why we order for viral isolation. So it is it can cause a debilitating paralysis, include the respiratory failure. So the problem pathology is at here, motor neuron. So the manifestation, patient might have there's no they didn't complete the immunization schedule. So there is a 3 presentation in polio. Patient can present with influenza-like symptoms. This is abortive poliomyelitis, and we have a non-paralytic poliomyelitis. There is an intense abortive poliomyelitis. Together with there is a stiffness in neck, muscle, and also the limb. And then a loss of reflex precedes the weakness within 24 hours. This is appendicitis. And then paralytic poliomyelitis, it has also several type presentation for this. Either involvement spinal, bulbar, or encephalitis. So severe muscle pain is present. There are sensory and motor phenomena. The distribution is usually spotty, and it is asymmetric flaccid paralysis. It is predominant at proximal area, extremity than distal. So the tender reflex will be mixed. However, the prominently absent. So investigation, we can order we can take the stool for virus isolation. We take 2, like I've mentioned, and then apart from that, we can order CSS analysis. It depends on phase. The finding would be pleocytosis with CNF involvement, which is a morphonuclear at the early course, and then afterward it becomes mononuclear. So management is mainly supportive since it is viral. So the aim is we like to limit the progress and prevent ensuing skeletal deformity. So I think it depends on the presentation. And then let's get back to the case. This last one. And then the child, the 12 years old, presented due to lower limb, and then he was previously healthy but developed sudden onset of fever and upper respiratory tract infection symptom, followed by bilateral lower limb weakness with numbness and right upper limb weakness. He also developed urinary retention. On examination, reflex in the both lower limbs could not be elicited. There was sensory level up to mid-thoracic. This mid-thoracic. GCS is 15. Okay. CSF analysis show pleocytosis and high protein. So anyone would like to guess? And the MRI show here. There is an intensity.
Transverse myelitis.
Okay. Distinction buat 2 kali. Okay, that's all from me. So this is the side by side, just supposing the feature of transverse myelitis, poliomyelitis, and Guillain-Barré. So you can read after this. This is my reference. With that, I open the floor for any question.
Hello.
Hello, yeah.
You can hear me. I think you are Your slides only come to me on clinical manifestation only.
Yes, I just add the sorry. So,
You have
sorry,
something in the presentation. Okay. The latest slides I cannot see.
Oh yeah. Everyone can see my slide now.
Yes.
Yes.
Which slide is it?
Currently is the last slide. Thank you.
Clinical. No, with me it is clinical manifestation.
Oh, okay, sorry. I think probably.
Anyone need to ask Haikal any question?
I try to stop share for a while. So, anyone would like to ask question? If no, we can proceed with Zaki probably.
Okay, the most important it is now I am a bit happy that you can mix the knowledge between the theoretical knowledge and practical application for certain diagnosis, which will give us the pathway for diagnosis and the differential diagnosis. And this art must be educated deeply for all of us, please. Okay. I think, did you read about contraindication of giving intramuscular injection in if you suspect polio?
I only have come encounter like if patient is acute illness, we cannot give the injection.
Yeah, because if you inject some muscle, it will be paralyzed.
Yes.
Better to be far away from giving any IM injection also. I need all of you to remember that acute flaccid paralysis, AFB, is notifiable disease. It's very important. Okay, we can start now with Zaki.
Okay, Zaki, you may control.
Yeah. Thank you, Haikal, and Assalamualaikum warahmatullahi wabarakatuh. And a very still morning, a very good morning to everyone. Can I share my screen, Haikal, or you want to use yours? Oh, it's okay. Let's use yours lah. So my name is Muhammad Zaki bin Jamaluddin, and I will be continuing our presentation for this morning, inshallah, with Floppy infant. So I hope you guys are still aware, conscious, alert, and still motivated to actually share my presentation. Hopefully, I will not take more. I will not take more time than I should lah, because we have to prepare for the Friday prayer for the brothers, also sisters lah, if you guys want to come. So for the Floppy infant, so let us begin with the outline. Right? Yeah. Okay, so my outline, I will be talking about the definition, definitely, and the causes, and then I will go to the clinical approach, how we actually approach this chief complaint of floppy infant, the history, physical examination, the investigation, and lastly, the principle of management. So when we are talking about floppy infant, there are two things that we need to be particular about, which are the strength of the child, the infant, and also the tone of the infant. So when we are talking about the strength, we are looking for if there is any weakness complaint where the patient, the child may have decreased ability to voluntarily and actively move their muscles. And these weaknesses can be either bilateral, generalized, or localized. And secondly, we must also take note of hypotonia, which is also a chief complaint when we are talking about floppy infant, where it is referring to the state of low muscle resistance to movement. This is particularly observable when we are doing the physical examination. Okay, so when we are talking about floppy infant, we are talking about the particular age group and a particular chief presentation. So we are talking about generalized hypotonia presenting at birth or in early life, and it can be associated with weakness or not. As we can see later on, when you are when we are clinically approaching a floppy infant, we will look whether the patient have any weakness or not, because this weakness present and absent will determine whether it is a central cause or a peripheral cause. Okay. Okay, this is what I meant. Okay, when we receive a patient with a hypotonia or generalized weakness, generalized hypotonia, then we will see in the clinical examination whether the patient have upper motor neuroscience or lower motor neuroscience. And later on, we can say that upper motor neuroscience will narrow down us to think about central causes, whereas lower motor neuroscience will narrow down our thinking to peripheral causes. And usually we will say that those with central causes will be floppy strong, whereas those with peripheral causes, we will say them as floppy weak. And the weak and strong is not referring to the strength per se, but referring more to the tone itself, because as we can see later on, the signs of the lower and upper motor neuron sign. Okay, this is from the Nelson Pediatric 21st edition, how they classify the causes of floppy infant and the pattern of weakness and the involvement. And this is quite useful for some of us, but however, I will use a more simple classification based on Nelson Essential, the 8th edition. So the Nelson Essential 8th edition simply divide the causes of floppy infant into two, which are central causes and also peripheral causes. So when we are talking about central causes, we are talking about these two anatomical sites, which are the brain and also the spinal cord. Whereas when we are talking about peripheral causes, we are talking about similarly what Brother Haikal have already presented. We are talking about anterior horn, peripheral nerve, neuromuscular junction, and so muscle. Okay. So let us move on with the central causes. Okay. For the central causes, definitely there are a lot of pathological causes that can lead to the presentation of hypotonia of floppy infant. Chromosomal disorder being the most prevalent, and later on with brain tumor, trauma, infection, ischemia, hemorrhage, demyelinating disease, metabolic disease, degenerative disease, a lot of differential that we can think of. And similarly with spinal cord, we can think of transverse myelitis, Brother Haikal presented, tumor, abscess, trauma, infection. So among the central causes, the one that I would like to highlight is regarding the chromosomal disorder. Again, we have listened. I believe we have been we have been told about Prader-Willi syndrome, where Prader-Willi syndrome is also can be. I believe we have heard about Prader-Willi syndrome as one of causes of short stature, but we can also take note of Prader-Willi syndrome as one of the cause of neonatal hypotonia, where Prader-Willi syndrome, as we have known before, is a disease of the chromosome 15, where the chromosome 15 either have a deletion in one of the sequence or it have a printing of a uniparental disomy, meaning that the chromosome is inherited solely from one parent, either mother or father. Particularly in Prader-Willi is the mother. So again, the clinical features of Prader-Willi syndrome. Okay, the chief complaint that we will receive is neonatal hypotonia, and usually the weaknesses of the hypotonia, I would say, for Prader-Willi syndrome is usually progressively decreasing, where the patient later on with age, the hypotonia and the weakness will be slowly decreasing lah. And initially, the patient will have feeding difficulty, swallowing difficulty, drooling, and so on. But however, later on, during infancy, the patient will later on develop obesity because of the weaknesses being lost, and the patient gaining strength, gaining tone, and so on. So the feeding will be more greater, and the patient will develop obesity after infancy. And there are also dysmorphic features lah, definitely for Prader-Willi syndrome, where we can see the patient have almond-shaped eyes and small hand and feet. I have a better picture after this to show the small hand and feet. So that's okay. And Prader-Willi syndrome is diagnosed by chromosomal analysis lah. And moving on with the peripheral causes. So I have mentioned before, there are 4 things that we need to consider when you're talking about peripheral causes, which are the anterior horn cell, peripheral nerve, the neuromuscular junction, and also the muscle. So for the anterior horn cell, I will be talking about the spinal muscular atrophy, and polymyalgia will be explained by Brother Haikal, and the peripheral nerve such as GBS also be explained by Brother Haikal. So for the spinal muscular atrophy, I believe all of us have been quite equipped with this knowledge, because I believe one of the clinical features that I would say which are quite distinguished of spinal muscular atrophy later on you will see. So spinal muscular atrophy is an autosomal recessive disorder where it involves the progressive degeneration of the anterior horn cells. And this degeneration is caused by the mutation in the survival motor neuron SMN1 gene. And the particular feature that we can see in spinal muscular atrophy is the progressive weakness and wasting of the skeletal muscle as the patient age. So there are three types predominant. There are actually a lot of types, around 5. But however, we can see about we should be equipped with 3 types of spinal muscular atrophy. The first type 1, type 2, and type 3. We also have type 0, which is the most severe one. But type 1 is presented when the patient is around birth to 3 months of age, and it occurs in 25% of the patient. It is a severe infantile form, and usually the prognosis is not that good lah. So basically the typing, the classification of SMA, the increasing in type is less severe it is. So SMA type 2 is a late infantile and more slowly progressive form. 50% of patients usually presented at the age of 3 months to 15 months. And lastly, type 3, chronic juvenile form, usually presented after 1 year of age. And usually the prognosis is quite better lah compared to the previous type. Okay, the clinical features of spinal muscular atrophy, the patient will be presented with severe hypotonia and generalized weakness. And one of the most important physical examination or physical finding that we will find is tongue fasciculation. And tongue fasciculation is usually can be seen when the patient is not crying or sleeping, is more better lah. And we can see also absence of deep tendon reflexes because it's a lower motor neuron lesion. And as you can see on your picture on the left, okay lah, definitely left. So you can see several features that would suggest that the patient have weakness. First of all, based on the observation, we can see that the patient have generalized weakness by the posture itself. So this posture is not quite, it can be seen, but it is called a frog-like posture. Do you know how frog-like look like? I believe all you guys have seen a frog before. Okay, so the frog-like posture meaning that the limbs are in a abducted position or in a relaxed position, whereas in normal infant usually they are flexed and also abducted in less abducted lah, I would say. And we can also see the chest is also have a weak wasting of the intercostal muscle chest because of this weakness. And you can see the leg is also abducted. Okay, that's for spinal muscular atrophy. And also, how do we diagnose spinal muscular atrophy is by genetic testing. That's one. And also, we can also look at the creatine kinase. But however, the creatine kinase usually is rather, it doesn't show any quite elevation as we thought it would be, but it can also be normal. And spinal muscular atrophy can also be diagnosed by electromyogram, where we can see fasciculation, fibrillation, and also a muscle biopsy can also be helpful, where we can see a group atrophy of the muscle. And lastly, the 2 other peripheral causes of junction, typo di situ. So the other 2 peripheral causes of floppy infant are diseases affecting the neuromuscular junction and also the muscle. And I would like to talk about the myasthenia gravis in this case. Junction. Okay, so myasthenia gravis, it is an autoimmune condition where our body, the patient's body will produce antibody that will block the acetylcholine receptor at the neuromuscular junction. And what this does is it will reduce the number of available receptor to actually receive the acetylcholine. And this making the muscle to have a stimulation is rather less because of the decreasing in number of the effective receptor. And one of the important clinical feature that we can see and we can elicit in the history is the rapid fatigability of the striated muscle, meaning that initially in the morning the patient is quite well, but however as the day goes on, the patient is complain of weakness progressively. And one of the features that we can see distinctively in myasthenia gravis is the oculomotor features. In this case, we can see the ptosis of the eye. Ptosis. Okay, so when we are talking about myasthenia gravis in children, there are 3 types that we must know. Sorry?
Yeah, changing the nasal tone is very important also.
Sorry, doctor?
Changing the nasal tone. We will speak by nasal tone.
Yes. Because of the...
You must notice it with the eye. It will give you a strong clue for the diagnosis. Okay.
Thank you, doctor. So there are 3 types of myasthenia gravis, which are juvenile, transient neonatal, and congenital. With all 3 of them have a different etiology leading them to the presentation. For the juvenile myasthenia gravis, usually presented in the late infancy or childhood, and it's a what's that? Okay. Juvenile mitral gravis usually is a spectrum of disease where the patient can present with a limited presentation with only ocular myasthenia, which only involve the eye, and it can be also progressive and potentially life-threatening, where it involve all the musculature, namely the respiratory system, also the digestive system, where the patient have difficulty in breathing and also difficulty in feeding lah. And secondly is usually the juvenile, the treatment is rather more or less similar to adult myasthenia gravis, where we will give the anti-acetylcholinesterase agents. And secondly, we have the transient neonatal. Okay, transient neonatal, as the name itself suggests, is a transient and usually present in the first hour to days after birth in neonates who is born with mothers where their mother have myasthenia gravis. And what this causes is that this myasthenia gravis in this mother, they will pass the antibody from the mother to the child. But however, only 10 to 20% will have these symptoms or signs of myasthenia gravis. And the treatment is usually supportive lah. We will give supportive treatment until the weakness remits, and then we can discharge the patient lah. And lastly, we have congenital. So congenital myasthenia gravis is not because of the antibody. It's not an autoimmune condition. But however, it is caused by the gene mutation itself in the neuromuscular junction. And usually the patient have a lifelong disability, and usually the treatment will not respond well to anti-acetylcholinesterase. Why is it not moving? Wait. Hey. Sorry, my internet connection is again unstable. Oh God. Haikal, can you go back to the diagram? I'm not sure why I cannot control. Go back to the diagram showing the peripheral nerve, the peripheral causes distribution. Another slide, okay, this one. So this is basically just a Okay, this is basically a summary of the peripheral causes. As we can see, disorder of the entry horn cell, and disorder of peripheral nerve, disorder of the neuromuscular junction, and lastly the muscle disorder. Okay, now let us move on to the clinical approach on how we actually approach patient coming, they've presented with generalized weakness and hypotonia. So we have known the causes and we have known the definition. Now we can go to the how we actually approach this sort of patient. So in the history, we asked about the onset of the weakness and the hypotonia, the weakness lah. So we asked whether it is presented during birth, immediately after birth, or it presented later in the childhood, later in the infancy, I would say. So we can say, oh, maybe if it presented during immediately after birth, maybe it's a congenital causes, whereas those who presented later in infancy, maybe it's an acquired causes. And lastly, we also asked about the cause of the hypotonia or weakness. So the cause usually can be indicative of what the causes could be. For example, if it is static, meaning that the weakness is like that ever since birth and never got worse and never recover, maybe it's a static causes. For example, cerebral palsy. And progressive, it could be spinal muscular atrophy, which is progressive in weaknesses, whereas waxing awareness can be seen in myasthenia gravis. And not only that, the weakness can not only can be seen through the limbs, through the trunk, but it can also be seen through several associated symptoms. For example, weak crying. Weak crying is indicative of the weak respiratory system. Poor feeding. Poor feeding is also indicative of poor digestive system, weakness of the digestive system. Similarly with drooling and rapid breathing because of the muscle, intercostal muscle and breathing muscle is weak. And then we must also carry on our history taking with the birth history. We ask about the fetal movements, the breech present, antenatally you can ask about the fetal movement, the presentation, whether it's breech or not, poly or oligohydramnios, because all of this may be indicative in utero causes. For example, maybe the patient have a neuromuscular disorder even in utero, hence causing them to have less fetal movement, because why breech presentation is a risk factor or is an indicator, because usually patient with neuromuscular disorder will have difficult ability to actually change their presentation as a baby. So that's one of the indicator. And next we can ask about birth trauma, birth inertia, delivery complication, low TH, Apgar score. All of these are indicators for hypoxic ischemic encephalopathy that we must rule out. And lastly, we ask about the family history, whether there is any consanguinity and or any other affected family members, because we are wary of congenital causes or genetic causes, chromosomal and so on. Okay, that's for the history. And coming to the examination, and the history definitely you need to tailor based on our causes, but generally that's how we should approach lah. For the examination, okay, we begin with the general appearance of the child. We look at the mental status. Is the patient aware or not? Because if the mental status is rather affected, we may think of central causes, meaning the brain or the brain lah, particularly, and the quality of crying, whether it's weak or not. And we look at the posture. The posture is quite a good signature of weakness. Like I mentioned before, the frog-like posture. And lastly, the dysmorphism, because we already well acute that dysmorphism is a features of syndromic diseases, and this syndromic disease can lead to neonatal hypotonia or infancy. Okay, these are some of the pictures. Unfortunately, I cannot show you video. For on the left, it is showing a tongue fasciculation. On the middle is showing again pertussis. On the right, what do you guys think on the right? What is it?
Element I itu tu.
Yes.
Really?
The Prader-Willi syndrome. And as you can see, also the hand and feet is rather small in proportion compared to the whole limb and also the body. One of the syndromic features of Prader-Willi syndrome. Okay, now moving on to the, after we have noted down the general appearance, now we move on to the neurological examination, where we want to determine whether this is an upper motor neuron or the lower motor neuron. So for the upper motor neuron, for the tone, initially, in acute phase of the disease, the patient will present with hypotonia also, is in decrease in tone. However, after several, as the time progress, it will increase in tone and lastly present with spasticity as compared to lower motor neuron, where the tone is rather decreased. And the reflexes is increased in upper motor neuron, whereas it's absent or decreased in lower motor neuron, and the Babinski reflex and atrophy fasciculation. Atrophy, why is it possible in both? Because it depends on the residual nerve conduction in the muscle. Okay, now for the neurological examination, I would like to emphasize on the tone, because we want to really assess whether the patient have hypotonia or not. So there are two tones that we need to assess. First is the postural tone. Secondly is the extremities tone, the tone of the extremities. So for the postural tone, there are three tests that we must do, which are the traction response, the vertical suspension, and also the horizontal suspension. I will show the picture later on. And for the extremity, there are a lot of tests that we can do actually, but I would like to focus on resting position, the scarf sign, also the pop tail angle. So for the resting position, I believe all of us have, I have said it before, the resting position, look at the posture of the baby. So these are the postural tone that we can assess. B is the traction, where we do the pull to sit test, where we pull the patient, and usually in patient with normal tone, their head will not lag that significantly, and usually after upon sitting, the head will return to its normal position. And C is the vertical suspension. Usually, patient with normal tone, we can hold them. Quite easily because the tone of the limb is there. Well, however, in patient with hypotonia, they tend to sleep. Sleep, not tidur. Sleep as in tergelincir. Sleep upon our holding position of the vertical suspension. They will sleep. And lastly, the D is the horizontal suspension, where we look, usually in normal tone, they will not flop that significantly. I believe a picture later on will show quite clearly. Okay, for example, the picture on the left is, this is the same patient with hypotonia. On the left is the pull to sit test, where we can see there's a significant head lag. Whereas in the second picture on the right is showing the horizontal suspension, where the patient is have the appearance of a rag doll. Basically a doll lah. Do you know? I think you guys know like doll, particularly sisters lah. When you hold the doll, why does it sound weird? When you hold the doll, the doll doesn't have any significant joint or any tone to actually help them to ensure their limb is in a fixed position as compared to doll. For example, the Annabelle doll. So that's what we describe lah, the rat doll presentation, the finding. And this is another cartoon, this depiction. I believe the left picture shows quite clearly the rat doll appearance, whereas the right side is a pull to sit test. Okay, this is the scarf sign, the polybital sign. So as I mentioned before, for extremities, there are a lot of tests, but I would like to talk about the 3 tests. First, we're looking at the posture itself. Secondly, we look at the scarf sign. Usually, in term infant, usually scarf sign is assessing the upper tone, the upper extremity tone, where we pull the patient's arm to form a scarf. As some of you guys may use scarf before. You just pull the hand and try to make a scarf around the neck. But however, in children with normal tone, usually the elbow will not go extend beyond the mid sternum, the sternum lah. But however, for children with hypotonia, we can pull until a full scarf lah, I would say. So that's how we assess the upper tone. Definitely the tone that we do rather commonly lah. Other than that, that is one of the sign. And secondly, for the lower extremities tone, we can do the pop little angle test. For the pop little angle test, we will flex the hip and also extend the knee. In children with normal tone, usually the knee cannot be extended more than 90 degrees on the right side. But however, if the patient have hypotonia, the knee can be extended rather more than 90 degree lah. So that's one of the sign of hypotonia of the lower limb. Okay, again, bear in mind when we are talking about hypotonia, think of the signs, whether it's upper motor neuron or lower motor neuron. If it's upper motor neuron, then we think about central causes, or if it is lower motor neuron, then we think about peripheral causes. Okay, these are the neurological examination finding that we will commonly find in floppy strong infant and also floppy weak infant. Another summary.
Yeah, the previous slide, please. Yeah, these are very, very important because during the exam, most of the students suppose if the patient got hypotonia that he is lower motor neuron, and he will go ahead to make it lower neuron. Take care, please. Sometimes he is floppy but strong, so you will find the upper motor neuron lesion with hypotonia. Okay, take care of this because many students are trapped at that and lose their competency. Okay, go ahead.
Okay, thank you, doctor. So yeah, bear in mind whenever we have a patient presented with hypotonia, don't immediately narrow down our causes or diagnosis only to lower motor neuron. Also think about upper motor neuron depending on the signs. Okay. So now we have talked about the examination. Lastly, we talk about the examination, the investigation, how we actually approach. So when the child is presented with neonatal hypotonia, we do the physical examination, and then we determine whether it is central or peripheral. So if it is central, then think about whether the patient have any dysmorphic features. Because if the patient do have focus on the left side first, if the patient do have dysmorphic features, then we think about chromosomal disorders or inherited disorder. Chromosomal disorder lah, genetic disorder, I would say. If it doesn't have any dysmorphic features, then we go with, I won't say immediately go to brain MRI, but the necessary essential suggests us to do so lah. However, do it accordingly to our thought during that time when the child is presented. And if the patient presented with peripheral, then we do creatine kinase, we do the SMA, the spinal muscular atrophy test, genetic study, and then muscle biopsy if we don't actually have the diagnosis. And if it's uncertain, then there's a lot of tests that we can do. So this is a rather simplified version from the necessary essential. But however, the necessary pediatric goes rather more detailed how we can actually approach. But this is up to you guys lah. I'm not sure whether I believe some of you guys can consume and understand this figure quite better rather than the necessary essential. This is another method on how we can approach. So moving on, lastly with the management. Okay, for the management, similarly, I would say know the cause and treat the underlying causes. That's the first treatment that we should do. And secondly, because the patient is presented with a weakness and hypotonia, so we will refer the patient for physiotherapy because we want to prevent contracture because the patient is not using the muscle rather as usual. So we want to prevent contracture. Secondly, we do occupational therapy because they will assist them to facilitate in their daily living. And thirdly, we must be aware that those with hypotonia and weakness usually have a weak respiratory system, weak cough test, I would say, weak cough reflex. So usually they will have, I wouldn't say usually, most of the case will have a respiratory infection. So we must treat them vigorously and also prescribe the patient with a vaccination of influenza, the flu vaccine particularly. And fourthly, we may refer the patient for orthopedic review because of the weaknesses. The patient is prone to have scoliosis and also subluxation of the hip. And lastly, feeding intervention because the weakness of the digestive system. Because the patient may have difficulty in feeding, then we may give nasogastric tube and so on, depending on the nutrition of the patient. And I believe that's all regarding the floppy infant, and these are my reference. Nelson Essential and also Nelson textbook, the illustrated textbook of pediatrics, and lastly the clinical approach by Van Ton. Okay, I open to the floor for any question.
So no one will ask. Should I ask? Today we are trying to get an important lesson, please. Sometimes I feel that more students are afraid of neurological examination. And when he came to the exam and asked for CNS examination, he is very clumsy. In spite CNS examination, one of the very, very, very straightforward which you can diagnose. You saw the motor, it is very for you to comment it is upper motor or no, or lower motor. All of you discuss that. But most of us during the clinical examination, we are not fulfilling the criteria for examination. It means you check, especially in infants, they are moody and you cannot do the job completely frank. So if you started by observation and then speak about the tone and the muscle power, and you must speak about muscle power for every group of muscle. So tone, muscle, and then you are going to do reflex. What you will do after reflexes? Becky?
Sorry, doctor?
After observation, we did muscle tone, power, and reflex. What else do you need to do?
Babinski and Clones.
Yes, what else?
What else?
Signs of incoordination.
Oh, yeah.
Ataxia. We must know how we examine ataxia. Your colleagues speak about even the tone of the voice will help us, okay, because it means lower motor, lower cranial nerve affections, okay. What the type of the speech, is it staccato speech or not? What about the eyes? What about the hands? What about the leg? What about, so it is very important. So even after we finish observation and the main three job, which is muscle tone, power, and muscle power and reflexes, we must comment about the CB, cerebral palsy. No, I just to remember, which is Colonas and Babinski, and you must comment about is any signs of incoordination, okay, which are ataxic, and if you are able, or the patient are able to walk, you must comment also about the gait, because we have the same criteria. We have spastic gait, we have atonic gait, we have waddling gait, we have ataxic gait, we have hemiplegic gait, and it is very easy. If you have any difficulties, who is my group? I will ask them a lot of homeworks. Is it group 2 for me or group 1?
Group 1.
I meant a group.
Oh, mentor, group 1.
Sorry?
Group 1.
Okay, so I will, inshallah, plan with you one maybe extra teaching about how to examine the nervous system. I will divide you. At least I need 8 candidates. Okay, one will speak about the motor examination. Another one will speak about general. How can we get impression about the patient situation by general observation? And it is very important. The third one will speak, will do the job of cranial nerve. How to examine cranial nerve. Before in the final pro, we bring one patient with 7th cranial nerve. Most of the candidates cannot pick at the start of, or even if they can pick, they don't know which side. Okay. Remember that Guillain-Barré syndrome. Hello, can you hear me?
Yes, we can.
Yes, Doctor.
Guillain-Barré syndrome can be presented by 7th cranial nerve palsy, and sometimes, which is more difficult, it can be presented by bilateral 7th cranial nerve palsy. So it is very important. So now one for general, one for motor, one for cranial nerve, one for incoordination or ataxia. It is a case on its own merit, and at least 2 of you need to do the gaits, the type of gait which we can see in neurological condition, spastic, ataxic, whatever. We have a lot, waddling gait, antalgic gait, hemiplegic gait, and it must be built professional. I mean, how is the normal walking manner, and how it is disturbed. So if you ask it, inshallah, I hope to prepare it. May give you up to 10 days to prepare it, and we can share even with the whole batch, because that's your time. Try to handle every week one case of neurology. Don't be satisfied by the other system only. Neurology and the cardiovascular needs more and more exposure. So we'll be confident, inshallah, during the exam. Okay? So don't forget how to differentiate between the very initial task, is it upper motor or lower motor neural lesion. Okay? And please, if you did job, try to make it complete. Okay? Don't forget also to look for every patient for the perineal area, if it has continence or not. For the back, if he has any deformity as a complication, or he has already some congenital anomaly like myelomeningocele or others. Okay. Don't forget to look for the chest in case of hypotonia, because usually they will got some deformity in the bone, and many of them has restrictive lung disease. Okay. Do you need to ask me any questions? Any other points you need to clarify? I think you must go through for your colleague presentation. They did a good job.
Doctor, I have one question.
Yes.
Regarding the floppy strong infant, why they have central hypotonia with upper motor neuron lesion? Is it due to the spinal shock, like we see in the case of stroke, where they will have transient lower motor neuron first, then progress to upper motor neuron?
No, it is not a must to have upper motor neuron, but sometimes they don't have lower motor. I mean, like patient of Down syndrome. Okay, he has a bit hypotonic, but it is not a must to have the signs of lower motor neuron lesion. Many cases can find the upper motor means the reflexes are high and the tone slightly looks high, not so low.